This is the NP Advocate podcast, where frontline clinicians share the real human stories behind the barriers in our healthcare system. These nurse practitioners are powerful advocates for themselves, their profession, and most importantly, for their patients. I'm Laura Starr, fellow nurse practitioner, and your host. Welcome to the NP Advocate. Kelly Straight is a Franklin and Marshall College alum from the class of 2001 with a BA in anthropology. She graduated with a BS in nursing in 2009 from Samuel Merritt University in California, and her family nurse practitioner doctorate of nursing practice from the University of San Francisco in 2020. Kelly's professional background includes experience as a nonprofit fundraising professional and a 15-year nursing career with experience in blood banking, internal medicine, acute care med-surg nursing, adjunct nursing instruction, and her current role as a family nurse practitioner in geriatrics. She is on the board of directors for her local California Association of Nurse Practitioners chapter and an active mentor to both nursing and nurse practitioner students. Hi, Kelly. Welcome to the podcast.
Hi, Laura. Thanks for having me.
Really appreciate you taking the time, and I'm excited to talk to you about your practice and maybe some barriers that come up. First of all, since this is a nursing podcast, can you tell me how you got into nursing?
I am a second career nurse, and I graduated in 2001 in the beginning of a recession. And so headed out into the workforce, and then 9/11 happened, which was a little bit derailing. Anyway, spent some time in the workforce and eventually landed in the not-for-profit world, and I became a development officer. So I was fundraiser for some very large organizations, national organizations, and I had to make a choice. I was like, I can't do this long term. Like I raise all this money for these organizations, and that's what I do. Like I want to be a direct service provider. And so the reason I say all this is I was torn between nursing school and library school.
Oh, interesting. Okay.
Yeah. And I was like, I don't know. Or then I was thinking, well, what if I did a master's of public health instead? Anyway, did a lot of soul searching, and I was like, nope, nursing. I'm going to do nursing. That's for me. I made a decision. And so then I started the process of taking all the prereqs. And if you are a liberal arts graduate like me, you did not take any math or science classes any more than you had to.
Yeah.
Because my degree is in anthropology. And so next thing you know, I'm taking intro to chem and organic chem for dum-dums. And my husband tutored me the whole way through it. So I was very lucky. Anyway, it took me a long time. And then I finished nursing school, and that was in 2009 in another recession.
Yes.
And so there's a theme. I graduated in 2009, and there are no jobs for people like me. Nobody wanted new grads. You couldn't get jobs anywhere. And here, my husband and I had moved to California in 2008, and I was sending applications to hospital systems in Pennsylvania and Ohio because that's where my family was. That's where I had been most recently. I mean, it was bad. It was bad. Anyway, eventually got a job, and then eventually transitioned into acute care. And at that point was like, okay, I think I've decided I want to do primary care. I saw these people come into the hospital, and I thought if these people had better access to primary care, maybe we could keep them out of acute care. Sounds nice, doesn't it? Right?
I follow.
That's how it should work, right?
Yeah.
So I apply in 2015. I start in 2016, and then graduate in 2020.
Okay.
Into the pandemic, right? In the heart of the pandemic.
You have
and
a pattern.
Again, nobody is hiring new grads.
Yeah.
This is why I'm not allowed to go back for a postmaster's in psych, mental health, because my husband said you can't go back because there might be another recession. So the answer is no. Answer is no. Anyway, that's the quick trajectory. And so ever since then, my first job was in geriatrics. on-site primary care, and I still do that with a different company now. So I, for me, I only see people in assisted living, memory care, and boarded care. I don't do private home patients just because I don't have that kind of time, unfortunately.
Yeah.
I work for an organization where we are fee for service, so we're not salary. And I say that just as a point of education. Not everybody works under that model. It does take some getting used to.
Yeah.
You have to learn how to do like billing and like, how do you figure out, like, am I billing for time or complexity? By the way, they don't teach you in school.
Yeah.
I asked about this once and they were like, well, you'll learn that on the job. Sure.
I have had one job that was, yes, I got paid what I billed. And it was very much a learning curve. I'm glad I got on the learning curve. I learned a ton, but yeah, it was a learning curve.
You do. And you worry. I mean, if you're me, you worry because it's like, oh, but I only did this much. And oh man, I'm probably underbilling. I am probably underbilling, which is my own problem.
Yeah.
Anyway, so within this medical group, we are fee for service. I get 50%. The other 50% goes to overhead. Physicians are 60-40, though we are primarily an APP organization because we do primary care in geriatrics.
Right. Yeah.
Pay is not great in primary care. And so, we're the ones filling the gap. I mean, truly, we are the ones filling the gap.
How do patients find you? Like how does a patient get on your panel?
Honestly, that's a great question. So I actually get a lot of referrals from home health and hospice, though that doesn't always work out. Again, if they're in a private home, I just can't accept. And I would like to say part of the reason why was because I worry too much about telemedicine. So telemedicine, as we all know, as of this recording, is in limbo.
Yeah.
Because ever since the end of the federal emergency response in May of 2023, CMS just kicks the can down the road and they just like approve it for another couple of months, another couple of months, and the government shutdown went into effect the day they were supposed to make the next decision. Yeah. And so I just always felt like, man, I'm going to get stuck. You have to fit those people into your schedule. So it goes back to how do I get these referrals? Most of my referrals come from my buildings that I'm in. I mean, honestly, assisted living and memory care, just like skilled nursing now, is owned by a lot of big companies. And so we have partnerships with these companies. And if it really isn't that hard to get referrals, honestly, if you are very consistent and if my schedule is I go to this place on Monday and I show up on time and, give good care, I get all the referrals. The challenge is in geriatrics is my patients go on hospice and they die. And so it is constant panel replacement. You can, if your patient is on hospice, you can see them as their PCP. It's the only person who can see you other than hospice, that's paid for by Medicare. And so I do see them, but I don't see them that often because frankly, hospice is at the wheel. And so they should be taking care of all of their needs. But I like to check in. Are they doing okay? Is there any chance they might discharge off? Is there anything they need? Weirdly, there are some hospices like, they won't fill levothyroxine. So I have to do it. Okay, fine, whatever. I don't care. It's not a big deal. So anyway, I follow them, but it's like every 2 months or so. So a lot of my referrals come from the buildings. I get family members who refer to me because I took care of mom and now their aunt is moving in, or I took care of an uncle and, now so-and-so, some family members moving into the community and they're like, oh, can you see my mom? Great. Yep. Happy to do it. So that's where a lot of my referrals come from.
And approximately how large is your average panel?
That is a good question. I was actually meaning to count that. So I want to say right now, because I just started seeing a few new patients. I think I'm around 130. Our sweet spot in our medical group is like around 150. I don't actually like a census that high. And the reason for that is my average is about 50, between 45 and 50 visits a week.
Okay.
More or less, like if there's a holiday or I was on vacation last week, so I got 0 visits, right?
Mm-hmm.
But if we're going into a holiday week, then I prioritize urgent needs only. I'm not going to bill 50 visits in 3 days, for example. I think about Thanksgiving coming up. So my average though is like 50 visits a week. I don't like a super high panel because one of the things that made me want to stay in this field
Mm-hmm.
is that I get to decide how much time I spend with my patient.
Mm.
I mean, yeah, they look at RVUs, but no one calls me up and says, Kelly, you're not billing enough visits. At the end of the day, I get paid for what I bill. So that's on me. But if that patient needs an hour-long visit, then they need an hour-long visit. And you never know in geriatrics, are you going to have a goals of care conversation?
Yeah.
And depending on how it goes, you might be billing advanced care planning. What is it? 99487? No, 99487. Yeah, 99487. Also, our billing codes are different because we bill the outpatient, the on-site codes are different from clinic codes. So ours start with 99. So maybe I'm doing advanced care planning. Maybe we're making a whole new post today, but out of nowhere. Sometimes I know we're going to talk about it, but sometimes I don't. And so it just depends. A hospital transitional care visit, hospital or SNF, that might be a whole hour because I have to go through the whole mess that is discharge orders. And believe you me, they're terrible. And I will tell you also, so probably the best generic term for what the field in which I work is RCFE. So that's residential care facility for the elderly. So that encapsulates your board and care, your ALF, your memory care. And so they have very specific guidelines from the state about how orders have to be written and medication reconciliation, because it's not necessarily nurses who work in these communities. Sometimes they have a nurse. Sometimes their only nurse is their resident services director, but that might be the only nurse, right? So it can take a long time to sit there and do that. So that being said, if I need to spend that amount of time, then that is the amount of time I need to spend. And so, yes, that does sometimes mean patients are waiting for me in the community. They know I'm going to be there. They might have to wait till I get there. But you know what? They'll get their turn too, where they need that hour-long visit out of the blue. So, you know, how long I see them for, how often I see them really does just vary based on their needs. And so, you know, this is why if I had a huge panel, it's really hard to give them the individualized attention they need. And the other thing that I have to spend a lot of time on is explaining, how does Medicare work to their adult children? Because if they don't already have Medicare, they may not understand. If they don't, if depending on if they have a supplemental plan, some of them are still working. So it really, like, you might have to spend a lot of time explaining Medicare covers this. One of the hardest things to do is talk to a family where their loved one came off hospice because, hey, they did great. They don't need hospice anymore.
They're not failing to thrive anymore.
Yeah, they felt better. And then having to explain, sorry, you don't meet criteria for that supplemental oxygen anymore. You know,
we're taking your hospital bed away.
We're taking your hospital bed away. Oh, the bedside table you really like. Nope, sorry, you can pay for that on Amazon. And I hate to say that because I hate to shill for the overlords, but truth be told, medical equipment is very reasonably priced on Amazon. And it will be delivered to the community where they live. Even better, right? That bedside commode, that shower chair on wheels. Sorry, none of that is covered. Like you can get it covered, but you have got to meet very strict criteria.
And you get like one, like pick all of the above, pick one.
You can have a bed, you can have the high back wheelchair, you can have the Hoyer lift. But the other stuff your family's buying. And so there's a lot of those. You know, I have some boomer patients. I don't have as many boomers as I do silent generation, but I have a lot of baby boomers whose kids might be my age.
Mm.
And so they really, really do not understand. And it is the rudest
Aw.
awakening you've ever seen.
Yeah.
It's
Yeah.
really, really hard. So
Yeah.
sometimes I'm explaining why Medicare is so complicated.
Yeah.
Sometimes I'm explaining why the hospital stay sucked so bad.
Yeah.
Not to put too fine a point on it, but I
Mhm.
mean, these patients are like a total mess sometimes when I get them.
Yeah.
And so there's just hospitalizations are just awful, even more
Mhm.
awful than when I left bedside 5 years ago.
Mhm.
And it's gotten worse. And they come to me and I'm just like, oh my God, what happened? What
Yeah.
happened here? What did they
Yeah.
do to you?
Mhm.
So anyway, there's so much that goes into these visits that for me, having a higher census is not
Mhm.
helpful. That's less
Yeah.
individualized attention. Because again, it's the attrition because of hospice and death. You're always
Mm.
taking on these new patients.
Lots of
And I will
intake.
tell
Yeah.
you, they are all very medically complex these days. It
Yeah.
is
Yeah.
really rare for me to get somebody who's
Mhm.
like, comes to me on, three things, maybe a vitamin, maybe some eye drops,
I'm
you know.
90 and I take an aspirin. Like
Yeah,
that's
they're like,
not
I
who
take
you're
an
seeing.
aspirin and a vitamin C. Have
Yeah.
I had that person? Yes, she was 100 years old.
Yeah.
It was wild.
Yeah.
But yeah, they don't last long at
Yeah.
that level of care, let me tell
Yeah.
you. So that's really what it is. I don't get the healthy people.
Mhm.
That being said, there are plenty of healthy people who are still living in their own homes independently and
Mhm.
and being an elder.
Mhm.
But if they can still do that, they stay at home.
Mhm.
And so my patients are in assisted living or memory care for a reason.
Mhm.
Um, because it just may come down to it's the safest place for them to be, even if they're still largely independent. They
Mhm.
just need to have a little extra oversight.
Yeah.
So,
Yeah. Well, especially the memory gets so complicated and difficult, the dementia
yes.
patients.
Yes.
Yeah.
Yeah. Yeah. It's very true. And they can be really hard to get out of their homes.
Yeah. Yeah. Well, and it can be so hard. Like it can be hard on them.
Uh-huh.
Their home, like that familiar environment's like one of the last things, like partially tethering them to reality. And
They
then,
change. They
yeah,
change significantly when they leave their home.
yeah,
They change if you move them from assisted living to memory care
mm,
down the hallway.
yeah,
They
yeah,
change. I mean, it kind of is what it is. And so, again, that's where you end up spending more time in person or on the phone with
hmm,
their kids explaining, like, I don't understand why mom seems more confused. And it's
hmm,
like, we moved her. I know it was down the hallway, but we moved her. Her
yeah,
environment's different. Her brain is working overtime.
yeah, yeah. So, what is like I mean, I imagine there's a lot of variety, but what does a normal day look like for you?
A usual day for me is minimum two communities, maybe three communities.
Mm,
The first thing I usually do is I check my email, I check Slack. We use Slack for messaging with our medical assistant. Um, looking at the faxes that have come in overnight, any refill requests, etc. Anything urgent, I think I have to deal with as
mm,
part of my day, and then I will head out to my first community of the day. I've got
mm,
a list of patients, like I know, okay, this person's due for a cognitive reassessment. This person, I'm trying to do there's a lot of gradual dose reduction of meds
mm, yeah,
in geriatrics because these people come to me on a ridiculous amount of medication.
hmm,
Many of them come on like pages of meds, just
yeah,
pages. They're
mm,
over medicated with their blood pressure medicine, often
hmm,
by the time I get to them or they get to me. So, maybe that's what I have in mind. Sometimes I'm doing wound care.
mm,
I do a lot of my own wound care. Yes, can I outsource to home health? Of course, I can. However, I will tell you there's a big difference because, I will sometimes inherit patients from a concierge physician group
mm,
and they don't look great. And I don't mean that as disrespect to the physicians, but
mhm,
they're, if it comes to wound care, they don't take the dressing off.
yeah.
They
Nurses,
will.
nurses are the queens of wound care.
That is the thing.
Yeah.
That is the thing.
Mhm,
So unless it's a vascular surgeon, and I have a
mhm,
great one that I work
mhm,
with, I love him so much. Um, PCP physicians they're not doing wound care. They're not checking it.
mm,
They're not checking the progress and they're just going along with whatever the home health agency is requesting or suggesting. And I'm like, how do you even know if, is that wound healed or not? Has it changed? Maybe it started as a bad skin tear. Because I will tell you, in the RCFE setting, there are some communities, they'll slap a Band-Aid on you and that is it.
Mm-hmm.
So then you have to bring in home health. Medicare is not paying me as a PCP to go out and do wound care 3 times a week.
Mm-hmm.
So I do have to rely on my home health colleagues, but I am checking that wound every 1 to 2 weeks. Is it healed? Is it not healed? Do we need to change the therapy? Because I have that training. And so they resolve a lot faster, I think, as a result. So sometimes I'm doing wound care. I mean, you never know. Sometimes I'm disimpacting them. So
thank you for doing that in the outpatient setting. Oh my goodness. I can't tell you how many consults. I mean, I'm almost 100% inpatient, and this person's in the hospital for constipation. Anyway,
yeah,
wow, mad props. I did not know that you were like taking that on. Yeah.
I have to, because these people will constipate so fast. And I have a patient where she actually had to learn the hard way. I told her, because she's got Parkinson's, and they have worse constipation than other people. Anyway, she's got a couple of things going on, and I was like, patient, believe me, you do not want me to have to do this. And I will tell you what you really don't want, and that is to go to the emergency room and have them do it. Well, sure enough, that is what happened a few weeks ago. And I was like, I'm thinking to myself, sometimes we got to learn the hard way. And not that I want this for anybody. It is humiliating.
Yeah.
Humiliating. And I walked in and she said, I heard your voice in my head. And I was like, oh, what did my voice say? And she said to me, I heard you tell me that if I had to do this, it would be awful. And you were right.
Oh, yeah.
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 Yeah. Because I know it's awful. Believe me, I've done it inpatient. I know how awful it is.
Yeah.
So sometimes, yeah. I mean, I have to ride herd on these people sometimes so much. You know, I might have to do serial KUBs in the again, it's outpatient. Like me and Cal Mobile are like best friends. Like, hey, I need another KUB because I have to see what's happening. Did we evacuate, right? All of the stool. I am desperate to keep these people out of the hospital.
Yeah.
I am desperate to keep them out. So my day could literally be anything. And sometimes like for us, like we're not doing those like Medicare annual wellness visits because I am seeing these people all the time. They do not need an annual wellness visit. That is all we do is wellness. Can I keep you out of the hospital?
Yeah.
You know, are we doing all the things that we need to do? So I see them pretty frequently. Like typically speaking, in the beginning, if I've just started to see a patient, I'll see them once a week for the first 4 weeks. And then depending on their needs, I might see them every 2 weeks, maybe every 4 weeks. And I don't go longer than 8 weeks without seeing a patient. I have a few who are just incredibly healthy and medically stable. And in the beginning, I saw them a lot and now they're fine. So I see them like every 8 weeks. Great. You know, but I see them frequently enough that I pick up on a change. So, you know, again, I might walk in saying, okay, I know I need to see these people and do these things, but I'll check in with the charge nurse, the director of nursing, the RSD, whomever, and say, hey, let's just run down the list. Let me know if there's anything that you're concerned about. Does anyone need med refills? And I run down the list and they're like, they give me the info and I'm like, okay, great. Maybe I need to see this person for a visit today. And that's how we do it. And it works pretty well.
Awesome. It sounds like incredibly hard work, and like whatever you're being paid, you're being underpaid for this because
I'm
like
definitely underpaid.
like keeping elderly people out of the hospital is saving resources. It's better for the patient because hospitals are scary. I mean, I'm an in-hospital provider. Hospitals are scary places to be. It's where bad things happen, like nosocomial infections, blood clots, falls. Like, you know, just all of the above. So anyways, the world needs more people like you doing the hard work. It's hard to keep people out of the hospital. It's a lot to take on. Sometimes it would be so much easier to be like, you know what, just go to the ER and then someone will deal with this in person.
Occasionally you do have to do that. Like there is a limit to how much can you do outpatient to keep them out.
Yeah.
And sometimes Like just for one example, I have a patient who I'm really struggling to deal with his hyponatremia because he has an ileostomy.
Mm.
And we were doing these serial labs and they just like the numbers weren't moving.
Mm.
And I got to the point where I was like, maybe I talked to his daughter and I said, just out of abundance of caution, like take him to the ED, let them replete him intravenously, and let's see if we can get him back to a normal level, and then we can work to maintain. And even then they didn't change anything when he discharged. And then I figured it out. I was like, it's coming out of his ostomy. It's coming out the ostomy. That's where it's all going.
Yeah. Yep.
I mean, it sounds stupid, like, duh, of course, but you don't even always think about that in the beginning, because you're like, how was he fine until he wasn't? And so there's a limit to just, we have a phlebotomist at the company who just goes and draws our labs. But, if Quest doesn't do them in time, typed in his date of birth wrong and couldn't find the results one time.
Oh.
I spent 38 minutes, 38, because I checked when I hung up, 38 minutes on the phone with customer service trying to figure out what happened to my results.
Yeah.
So, there is a limit. Yes, I can do outpatient. I can do EKGs, x-rays, ultrasound, labs, but not everything can be done in the field. For one thing, you can't do a BNP in the field because they have to be frozen right away. So no BNPs. What you can't do anymore is a peripheral smear, which is killing me. And I have not had time to deal with that. Unless I do the smear myself. Well, I'm sorry, excuse me. Let me get my telescope, my microscope and my supplies out.
I do not own a microscope.
How would I even bill this? The amount of time I would have to spend going with my phlebotomist to then do the smear, affix it, hand it to her, and take it to the lab. Like, how stupid is this?
Yeah.
So this is sometimes the thing. You get stuck. You get stuck, and you occasionally have to send them to the ED. You just don't have a choice. Obviously, there are some things where it's the rules of the community. If they have fallen and they say they hit their head, sorry, do not pass go. 911 it is, off you go, because that's a liability for them, and those are the rules of the community. And so, I mean, family can deny transport and all of that, but sometimes I cannot. Sometimes they develop a subdural hematoma.
Yeah. I mean, there's reasons for those
things
rules.
Happen. Things happen. And at the same time too, like, part of why it is so important for me and my medical group to keep these people out of the hospital, who gets really honked off these days at being called? EMS. EMS is not always friendly.
Yeah.
Sometimes they give me a hard time. I called them. Now, I will tell you, it's rare. It's rare for them to give me pushback, because if I had to call myself, I called you for a very good reason, not because so-and-so patient fell for the 8,000th time and they know this lady and there's never anything wrong with her. But, their resources are thin as well. And so they get mad and they push back a lot on these communities. So if I can keep them out of the hospital in the first place, that also saves the relationship with the local EMS.
Yeah.
So there's a lot. It's resources. It's resources.
Unfortunate that everyone's getting sort of pulled in so many different directions.
They are. It really just feels like there's no winning sometimes.
Yeah. Well, as we both know, because we've talked about it in the past, I know we were both excited about the potential for California nurse practitioners to be able to sign death certificates because it affects our So, AB 583 by Gail Pellerin did pass this year. It'll go into effect next year in California. What like, what does this mean for you? What is your workflow currently when one of your patients dies and you can't sign the death certificate?
That is a great question because as much as we can, we try to make sure our patients are on hospice.
Hmm.
But you know what? Sometimes people die.
Yeah.
They die not on hospice. They die
Yeah.
unpredictably.
Yeah.
I had a patient just kind of die in her sleep. Last year it was weird. I had two like die back to back in like 30 days. One lady had an acute coronary,
Mm-hmm.
had an acute coronary. It was
Yeah.
wild.
Yeah.
And the really wild thing was she'd been in the emergency room like 5 days prior, right?
Mm.
Like it was just, you know, I will also say in this work of geriatrics, if there's any sort of cognitive impairment, figuring out what is wrong is very difficult at times.
Mm. Yeah.
And so you can't just go running around doing EKGs on everybody just because they don't feel good,
Yeah.
you know, or whatever. I mean, that lady's situation was kind of different, but I will tell you it's, you know, for me, it means that one, I have to talk to my collaborative physician because it's
Hmm.
going to be his signature we put on there, not
Hmm.
mine.
Right.
He does not know this patient. He's never seen this patient.
Yeah.
But I might have to go through. Sometimes it's because you just need advice, right? Like,
Mm.
you know, obviously we don't know what happened, but this is what like this is based on what EMS and the facility have told us. Like this is likely what happened. Okay, great. We figure it out. We do it. But I had a situation once where it can create a big holdup because the patient had been sent to the hospital over a weekend with urosepsis, and the hospital declined to fill out the death certificate,
Mm.
and they erroneously called the coroner, believing that she had suffered from some sort of traumatic, like car accident that resulted in her paraplegia, and it instead was because she had a tumor on her
Mm.
C-spine.
Mm.
So now the coroner's office is involved,
Yeah.
and the collaborative physician I was working with at the time um, just wasn't filling it out the way they wanted it. And
Mm.
so they would go through me, and I would have to go to my collaborative physician and say, I am so sorry to bother you, but uh, coroner's office said they want this as the primary and this as the secondary. And oh, you forgot to mention this other thing. I mean, we went round and round and round. And those delays mean the family cannot plan their funeral for their loved
Mm.
one
Hmm.
or whatever their memorial service or however it is they want to grieve, do whatever.
Yeah.
The holdup is happening because the coroner does not like what we've written, and until it is correct, they will not release the body.
Yeah. So it's you're stuck playing some morbid game of telephone
It
because you know the
really difficult.
patient, but
Yeah,
you can't sign the paper.
right. And if
Yeah.
I could have been allowed to do that,
Mhm.
I could have just done what they'd asked, and then we could have been done like 4 days earlier. I mean,
Yeah.
really, because I
Yeah.
was thinking, I was like, well, you know, I'm telling the coroner's office, well, I'm sorry, hospital ABC was wrong.
Yeah.
She has a tumor on her spine.
Right.
They're like, well, that's too bad because it already went to the coroner, so we got to do it this way anyway. And it's like,
Yeah.
great, of course we do.
Yeah.
So that's the issue is the delay for the family, and I will tell you that is a big deal. I mean, my mom passed away in April this
Mm.
year, and you know we were in Indianapolis,
Mm.
and I am from California now.
Yeah.
And so I'm there
Mhm.
and I am trying to close bank accounts and
Mhm.
forward the mail and do things. And you can't do that stuff without your death certificate, which you need to have signed.
Yeah. Yeah.
So I got very lucky in that the hospice attending physician signed it very quickly,
Mm.
and I was able to go close her final bank account before my flight the next day.
Oh, right. Yeah.
Because if I was going to have to do it from afar, we were
Mm.
going to have to do this crazy, like, um, dance with USPS and certified mail and signatures and all this other stuff. And it was going to take weeks to close that bank account.
Yeah.
So it really makes a big difference to get
Yeah.
that death certificate in time, and to get the body released in time so that you can do whatever it is that you need to do, again, as part of your morning practices. The holdup can be very distressing for a grieving family.
Yeah. It's already hard. And now we just made it harder.
It is. And for me, who already works in the medical field and is already pretty used to this, like, even for me, it's like, oh my God, why is this so difficult? And so it's just, there's so many things to think of. And the last thing you want is this holdup. So for someone like me, who, sometimes I need to sign a death certificate, this is a huge help to my families.
Yeah.
I want to help them grieve, and I want to help them tie up all those loose ends and start working on all the things you have to do when your loved one has died. Like, it is a monumental amount of work.
Yeah.
When your loved one has died and you are in the hot seat to take care of all of it. That's a lot of work. So if you can just do this one thing to make it easier, this is a huge, huge help. Huge help.
I'm curious. I'm curious about the public health implications. Like, having accurate death certificates is important for tracking and everything. And so do you, like, how accurate would you say the death certificates are that you're not signing on your patients currently? Like, do you think this is going to help make things more accurate?
I mean, it certainly has the capacity to make it more accurate. I'll tell you, my mother's death certificate is not accurate. She did not die from congestive heart failure. That was the first listed disease state. And I was like, no, wrong.
Yeah.
Incorrect.
Yeah.
I mean, it just made me mad.
Right.
Because it's not right. It's not correct. I know it's not correct. But there's huge implications for this. Because the thing is, like, again, most of my patients are dying on hospice. Now, what hospice is going to put on that death certificate is the admitting diagnosis. Now, this is where it gets a little bit tricky, and I would have to talk to my hospice colleagues about how they handle that. Because again, it's the physicians that sign those, right? Not the nurse practitioners or the PAs. So they've got to go with the admitting diagnosis as the primary, but then you've got secondary and tertiary too.
Right.
So, that's where you might see, I don't want to say you see inaccuracy, but like, there's a lot of nuance in why a person dies.
Yeah.
There's a lot of nuance. And there's a lot of contributing factors. And so, you might say that somebody died from aspiration pneumonia secondary to their, end stage Alzheimer's disease or whatever, but it's the Alzheimer's disease at the end,
Yeah.
So it will be interesting to see how it changes the reporting of what people are dying from, right?
Yeah.
Because it's not always super obvious, right? It's just not.
Well, I just want, and like, how many, I'm back to your like ER patient with a spine tumor, like a car accident did not cause this. Like, I can imagine like a different universe where it was like this like mysterious non-existent car accident ends up on her death certificate, which never happened.
Yeah, exactly. I did one time have a GIP patient when I was still working inpatient as a bedside nurse, who was a coroner's case, and it also car accident. So weird, but it was like from 25 years ago. But somehow the palliative team, they knew about that, and so we were very clear always, during a bedside report of like, don't touch them, just get them in the shroud and off they go, right? But like, well, I wonder what went on that person's death certificate.
Yeah.
Interesting, right? So sometimes it's super obvious and sometimes it's just not. And again, like, it's the holdup and what it does to families is just, they've got enough to deal with, right? So this is just, this always just goes back to access to care and filling in the gaps, right?
Mm-hmm.
If it's not us, then who?
Yeah.
If not us, then who? Who?
Yeah.
If they're not dying in acute care and they're not dying on hospice, who is the person responsible when they have an unexpected death? It's the PCP. Who is doing primary care these days?
Yeah. No, yeah, it's NPs and PAs. Yeah.
Yeah,
100%.
exactly. So this makes sense. This is a positive step in ensuring better patient care, better access to care.
Yeah. Yeah. And long overdue.
Yeah, frankly,
Yeah.
frankly, long overdue.
Yeah.
So I'm very excited about this. So I'm hopeful that next we can work on the letters of incapacity. That is also my big bugaboo. Because I'll tell you, that's the thing I sign all the time.
Yeah. Yeah. I was just, I was just reviewing that, those statutes, cause there's I don't know, are you dealing with the, like, the incapacity to oh my God, to consent to their own procedures? Or are you like doing like conservatorship?
Oh God, sometimes I do conservatorship. Can I tell you how labor intensive that is?
Yeah. Yeah.
That is the most labor intensive thing I have ever done. Is to have to assist with conservatorship. So it's a lot of, most medical groups have a standard template they use for medical and financial incapacity. Sometimes it's both. Because in geriatrics, we have a lot of dementia in our patient population. It stands to reason we're going to be filling these out a lot, right?
Yeah.
Families need to be able to liquidate assets to pay for memory care. Memory care, I will tell you, this is not like an official state average. This is average of just the bill. I go somewhere between like 12 to 14 communities. The average is like 10 grand a month.
Yeah.
That's $120,000 a year. Once you've blown through mom, dad, grandma's, whose ever money in their retirement accounts, you've exhausted all of those, you're selling their home.
Yeah.
Right. So that's often what it comes down to, or it becomes apparent they cannot manage their own finances. I have a patient right now where we are going through that, and I have had to urge his DPOAs. He and his wife, also my patient, I provided modified letters for them where they should still be included in medical decision making. And I'm very clear in that they can participate in the process as they should be allowed to do. However, they need to make these decisions in conjunction with their PLA. But with the financial stuff, if you can't pay your bills, you keep getting locked out, your bills are past due, services are being cut off. Yeah. It's really important to provide that documentation. Always they want to see it, right? Like any financial institution wants to see it. Title companies want two letters. And let me tell you how hard that is when, again, who's in primary care? PAs and NPs, right? There aren't enough physicians to go around. So if they need that second letter and I only have one collaborative physician, we got to get creative sometimes to find that other letter.
Yeah.
Sometimes it comes from hospice. Sometimes I will tell them, I get a lot of these patients who they're just so difficult for them to leave the community. Either it's really difficult because of their dementia to get them out. Like it's just a struggle, or there's a mobility issue. And so I might say, you know what, schedule one last appointment with that, Sutter PCP, that Stanford PCP, whomever, right? Go get that letter of incapacity. I'll provide the other one, right? Because, the reality is I'm on site. I see them all the time and I can see them quickly, right? And I inherit a lot of people from the big, huge medical groups. Large medical groups are not friendly to the elderly. They're not.
Yeah.
When you think about the structure, right? You have to plan really far in advance. Well, I might not get that appointment for like 6 weeks. Well, they're done being sick now. Or they went to the emergency room and got admitted. It was too late, right? Because we couldn't get an appointment in time. Finding parking. Oh my God, I don't have a handicap placard.
Yeah.
Oh my God, I couldn't get my mom out of the car. She couldn't stand up to get out of the car, right? They struggle to sit in the waiting room. If they have dementia, they're a little disinhibited and they say some impolite things to the other people waiting. They start to get agitated because they have to wait too long. Like, it is really difficult, for a lot of my patients to go out. And I know this because they might still see a specialist. It's really hard for them to get out and about. So there's a reason why, my medical group exists and the work we do, because we're not concierge. We don't charge people extra money. We just bill Medicare and their supplemental insurance, right? We're like an office on wheels. Like, all my junk is in the car, right? I've got a little roller bag with all my goodies that I need. So it's really important to have that access to care, because it's really hard for them to leave. It's hard for them to leave where they live, right? So anyway, if there's one thing I'm asked, like one paperwork item I'm asked for the most, it's the letters of incapacity, followed by FMLA, followed by conservatorship, because conservatorship is unfortunately part of the work of a PCP for a variety of reasons. And so it's a lot. And again, I will tell you, those conservatorship forms, whose name do you think has been on all those forms that I have filled
out? Supervising physician.
Yep. Yeah. I did all the work. I did all the work. I filled it out. It's the tiniest print you've ever seen, and 8 zillion little boxes asking you about their incapacity and why they need to be conserved, and usually it's related to, there's usually a cognitive impairment or an already diagnosed dementia for my patients, a dementia diagnosis, and somebody else needs to be assigned to be in charge of that person's, care, right, and decision making for a variety of reasons. Really, the forms are extensive. So trust me, I do not get paid enough.
Well, thank you so much for talking with me. Is there anything that we didn't bring up that you wanted to circle back to?
That's a good question. I mean, we need more people in geriatrics. So if you know anyone, the more the merrier, right? Like this really is, this is a specialty in and of itself. And there just are not enough of us for this very quickly aging population. And these issues, right? Like, these issues are just going to keep cropping up, right? So, this is where it really matters to have more autonomy in your practice, to take care of the things you need to take care of for your patients. No one's got time to wait. Physicians do not want to do this. They do not want to do it. And I don't want to speak for my physician colleagues, and I appreciate those of who want to do this and that they stay, because it's incredibly hard, but it just does not pay well. And I get it. People have mortgages to pay. They've got kids they want to send to school. Some of us are financially responsible for our aging parents, and it's not cheap. Let me tell you. My mom's assisted living bill was not cheap, and we were paying most of it. So it really is such a big deal that there are not enough of us in primary care. And so the more things that we have the ability to do without having to wait for a physician to co-sign or for them to review and sign, the faster we can take care of things for the patients and their families.
Well, I just want to say, I think your practice is so, in addition to being essential, is so cool. Like, the geriatrics, psychiatry, wound care, like, you're doing all of it. And that's just amazing. And also just such a needed service for your patients. So thank you on behalf of your patients.
Oh, thank you. It is, I will say, there's never a dull moment. Never a dull moment. And I will also say, all those years as a bedside nurse, it pays off in ways you can't even imagine, because all skill sets can be applicable.
Yeah.
When you make that transition from RN to NP, right? And, we should never discount people's prior experience because you just never know when that's going to turn out to be super helpful.
Yeah, absolutely.
So those skills don't go to waste is all I am saying.
100%.
Well, thank you for this. This was great. I'm glad we got to have this conversation.
Yeah, me too. Thank you so much. I think this was great. I learned a lot. We'll stay in touch. We'll keep knocking down barriers.
That's right. Fighting the good fight.
Yeah, absolutely. Well, you have a good night, Kelly.
Thanks, Laura. You too. Thanks for having me.
Here's a little more information about the legislation mentioned in today's episode. Assembly Bill 583 was signed into law by Governor Newsom of California in 2025. Starting on July 1st, 2026, licensed nurse practitioners will be added to the group of healthcare professionals who can sign death certificates. This important piece of legislation was authored by Assemblymember Pellerin and supported by the California Association of Nurse Practitioners. If you are a nurse practitioner who has experienced barriers in your clinical practice, either at the institutional, state, or federal level, and you want to talk about it, I'd love to connect with you. Please email me at laura@npadvocate.com. That's LAURA@npadvocate.com. Thanks for listening and hope you'll tune in next time. This has been the NP Advocate Podcast.